good. I thought I might mention too, I think you're aware that the mask mandate dropped in Louisiana last week, so masks are optional, and feel free to wear one if you're more comfortable or not. It's totally up to you. So we're going into the next session now, and I'd like to introduce the chair, who will then be introducing her own people on the faculty. I'd like to welcome Professor Carol Peden, who's a very old friend of mine. We actually trained together in the UK in the Southwest, and even had our first attending jobs at the same place in Bath. And then our trajectory sort of went away and then came back again a few years, and then we're both now in the USA practicing. She is an adjunct professor of anesthesiology at USC Keck and also at my own University of Pennsylvania. She's senior associate tutor at the University of Oxford, which we all know is the best university in the world, have to get that in, and a visiting professor at the University of Bath. She's immediate past chair of the American Society of Anesthesiologists' Perioperative Brain Health Initiative, so really she is the perfect person to chair this next session. She's also the new Executive Director for Clinical Quality for the Blue Cross Blue Shield Association. It's a federation which actually covers 109 million people for healthcare, in other words, 1 in 3 Americans. So an exciting new role she's taking on. And basically she's got expertise in designing and leading improvement and innovation projects around the world, and was named Public Health Innovator of the Year in 2016 by Harvard School of Public Health for her work to improve outcomes in high-risk surgical patients. So I'd like to welcome to the stage Carol Peden.
Thank you, Mike, and thank you, Dr. Coombs, for a very inspirational and important talk. And I think we're going to touch on this because, you know, there is also some disparity for older patients, and we're going to discuss that in this session. So I am very happy to welcome two experts and good friends, actually. And our first speaker is Dr. Liz Everett. She is a truly international because she has an associate professorship at Weill Cornell in New York and at the University of Melbourne in Australia. And she really is one of the world's experts. She's a PhD neuroscientist. She's in the Department of Anesthesiology. And there is no better person to tell you about delirium and perioperative neurocognitive disorders.
Thank you all for being here this afternoon, and thank you to the organisers for inviting me to give you this talk. Really what I'm going to talk about is defining what perioperative neurocognitive disorders are in preparation for the next two speakers who will address why we need to focus around this with an ERAS protocol to avoid these serious complications. So, I have no disclosures that are relevant to this presentation. I'm going to talk about what perioperative neurocognitive disorders are, and then specifically postoperative delirium and postoperative neurocognitive disorder. Very briefly touch on biomarkers. I'm just going to start this. How do I start the timer? Sorry, I've just realised that otherwise... Oh, here we go. It's going. Thank you. Biomarkers, intervention strategies, and how brain ERAS might be a solution to a very significant problem. So first of all, perioperative neurocognitive disorders are associated with anaesthesia and surgery in older individuals. For most of the population, they will undergo their anaesthesia and surgery, and they'll have an uneventful recovery. But for a significant proportion of patients, that won't be the case, and up to 60% of surgical patients who are 65 years or more will experience an episode of postoperative delirium during their admission. Out to 30 days, we use the term delayed neurocognitive recovery, and I'll talk about the definition of that in a moment. And what we're seeing there is between 10 and 50% of patients who just haven't recovered as quickly as you would expect them to and are experiencing either continuing delirium or initial stage in observations of neurocognitive disorder, such as decline in ability to memorise, use memory in daily functions, and executive function in particular. 1 to 12 months, medium and late postoperative neurocognitive disorder, and we define this as mild or major. Mild neurocognitive disorder is aligned with mild cognitive impairment in the community, and major neurocognitive disorder is aligned with dementia. These are recent classifications and definitions and terms that were published in 2018. What we're really trying to do with this work is identify the overlap between how the community talks about neurocognitive disorders in elderly people and how we talk about them. In perioperative medicine, for more than 100 years, we've been talking about postoperative cognitive dysfunction, which was purely an objective assessment of a decline in function. It didn't take into account any subjective complaint from either the patient or their family, and we know that to be a significant indicator of possible decline in the community, nor did we take into account anything about functional decline. And obviously, the most significant impact of any cognitive decline is when it impacts on your function. Beyond 12 months and out to years postoperatively, we talk about mild and major neurocognitive disorder, again aligned with MCI and dementia. We wouldn't use the specifier postoperative past 12 months. We are using the specifier up to 12 months to identify the temporal association of the cognitive impairment with the anaesthesia and surgery. But again, a lot of studies haven't used more than one baseline assessment in this field. We have no idea of the trajectory of cognition in that patient preoperatively until we understand that trajectory. What the impact of the anaesthesia and surgery is on the patient in terms of cognition and function is still unclear. But we do see a measurable decline in function in a significant proportion of patients. In some work we did in cardiac surgery patients, 30% of patients had classification, a new classification for dementia 5 years post-operatively. So there is a significant increase in risk of dementia, and certainly we know that also to be the case with post-operative delirium. Not only are there problems post-operatively, but we also have to focus on the patient. So the patient who's coming to you who might have a preoperative assessment, in all likelihood, even if they do have subtle cognitive impairment, you will not be able to notice that without doing appropriate testing. So the patient's age, the likelihood of undiagnosed cognitive impairment or in fact diagnosed mild cognitive impairment or dementia, the comorbid disease, their frailty, and whether or not they have impaired instrumental activities of daily living are all characteristics that make those patients vulnerable to the post-operative poor outcomes we're talking about with perioperative neurocognitive disorders. So just to quickly cover the definition, we are using from the DSM-5, which aligns, as I said, with MCI and dementia, which are the National Institute of Ageing recommendations. There's a subtle change in cognition in at least one test or domain. For mild neurocognitive disorder, the decline is 1 to 2 standard deviations below controls or norms, and for major neurocognitive disorder, it's 2 or more standard deviations below controls or norms. It has to be a change over time. We're interested in a decline over time, not a cross-sectional assessment, and it occurs most frequently in people 65 years or more. The known predictors are age, IQ, and subtle cognitive impairment. And as I said, we do have to have a subjective assessment and an assessment of daily living function. So this is just to highlight that the likelihood is that what we're seeing perioperatively are very similar or the same as what we're seeing in the community in terms of cognitive impairment in elderly people. What we don't know is exactly how they cross over, what the trajectory is, and whether or not the event of anaesthesia and surgery initiates or exacerbates the further cognitive and functional decline post-operatively. So post-operative delirium is an acute onset and follows a fluctuating course, so it's very important to assess patients frequently and use a validated tool. The patients often have inattention, a decreased awareness of their environment, an altered level of consciousness and disorganised thinking or some confusion. And just, you'll see on the right, just to clarify what the criteria are for delirium to be positive is that you must have feature 1 and feature 2, so an acute change and inattention, and then either an altered level of consciousness, when we usually use the Richmond Agitation Sedation Score to assess that, or disorganised thinking. And there are a number of tools that are used to assess this. Some are very useful and have great training for research studies. Unfortunately, in the routine clinical environment, these take time and training and are unfortunately infrequently used. We know that delirium is associated with significant poor long-term outcomes. Patients are much more likely to die, they're at risk of falls, they're much more likely to experience progression to dementia and institutionalisation. On the left, you can see a list of possible prevention strategies, which are based on Sharon Inouye and Ed Marcantonio's HELP guidelines, which I'll talk about a little more later in the talk, but just to highlight that these are the sorts of things that with education and knowledge, patients and their families can actually help prevent an episode of delirium from occurring by being with the patient and by ensuring that these things happen post-surgery on the ward. So there are predisposing factors for post-operative delirium that we really can't do anything about. For example, increasing age. Frailty, we know, puts people at high risk of post-operative delirium, but I will just put an asterisk there because, in fact, frailty may be modifiable if we have prehabilitation. So something to think about, which I'll talk about later as well. Polypharmacy, cerebrovascular disease, the degree of surgery or how major the surgery is, whether or not the surgery is emergent. And we know that anyone with even subtle impairment is at greater risk of suffering perioperative, post-operative delirium and neurocognitive disorder. And those patients who have had delirium in the past are more likely to have another episode of delirium. Then we have modifiable precipitating factors. These are factors that we perhaps have some control over modifying both intra and perioperatively on the ward. So pain, particularly looking at multimodal analgesia and avoiding opioids. Disorientation is something we can do something about with the help of nursing staff and allied health. Sleep is obviously a problem on the ward. The Beers criteria are a great list if you're interested in looking at the types of medications that are likely to put patients at risk of delirium. Infections, obviously, bladder catheters are very, very commonly associated with an episode of delirium. So just to give you an example of how these patient factors might impact on the outcome of the surgical process in an older person, let's say we have a female who's somewhere between 75 and 84 having a cholecystectomy. The patient is independent, has some mild systemic disease, but really is not, it doesn't have a high comorbid disease burden. They're not obese. They have some subtle cognitive impairment, but they're managing at home with support. So if we plug all those things into the NESQIP calculator, you'll see that the patient has a little bit of an increased risk of being discharged to a rehab facility, but apart from that, the degree of risk doesn't look too awful. The NESQIP now have a geriatric component to the scale where you can input other factors that are associated with increased age that might put the patient at higher vulnerability. If we do that for this lady, what we actually find is that although her physiological risk is not high, her risk of delirium is nearly 25%. Her risk of functional decline is over 40%. So I think this is a really stark presentation of the risk that just being old and vulnerable and sick puts you at in what is perceived to be a not particularly major operation. So what about postoperative neurocognitive disorder? I'm going to present postoperative cognitive dysfunction data here to give you an idea, because we're still in the beginnings of the using the new criteria. Around 16 to 20% of patients at 3 months having either minor sedation for a minor procedure like a coronary angiography or cardiopulmonary bypass for CABG surgery, similar risk for neurocognitive disorder at 3 months. This is some more recent work, and again, looking at in non-cardiac surgery on the left-hand side, 12 to 21% at 3 months, and in the postoperative brain health group, they said between 10 and 40%, but they did include postoperative delirium in that, so that accounts for why that's a bit higher than just for neurocognitive disorder. Preoperative cognitive function is, as I said, the most significant risk factor for perioperative neurocognitive disorders, postoperative delirium. And you can see from these two studies that in non-cardiac surgery, 32% of patients had preoperative subtle impairment. These are a group of patients who all had a mini-mental of 26 or more to gain entry to the study. They are not overtly cognitively impaired at all. Similarly, following cardiac surgery at the, prior to left heart catheterisation, half the patients met criteria for mild cognitive impairment. So patients over 65 who are presenting for anaesthesia and surgery are already presenting at greater risk. Frailty, as I've already said, is a significant risk factor for postoperative delirium and neurocognitive disorders. I won't go into this in any detail, but it is something that we should be assessing for preoperatively. What are the impacts of perioperative neurocognitive disorders on patients? It increases their length of stay in hospital, which increases their exposure to complications. It increases the risks of unplanned ICU admission, reduced quality of life, increased mortality, increased risk of dementia and institutionalisation. So these are the most common complications that surgical patients will experience, and they have serious consequences. I won't go into biomarkers, as I said, but I just wanted to put this up to highlight the fact that the biomarkers we are looking at in perioperative medicine associated with the surgical procedure are the same biomarkers that we see in the Alzheimer's disease and related dementias population. So the likelihood of some overlap is evident, but we still have a lot more work to do with regard to the mechanisms behind these disorders and whether they're the same, following the same sort of pathophysiology as Alzheimer's disease and related dementias. Intervention strategies, I've already mentioned the HELP interventions from Sharon Anaway and Ed Marcantonio. They are reported to reduce delirium by up to 40% in hospitalised patients post-surgery. And they are things that families and nursing staff and allied health staff can be trained to assist with. In terms of intraoperative strategies, we really haven't gotten very far with finding a culprit here. There's no evidence for specific anaesthetic agents, no difference between regional or general anaesthesia in terms of the incidence of neurocognitive disorders. There does look to be an association with inflammation, and our hypothesis at the moment, which also aligns with what we see in other related dementias, is that inflammation leading to neuroinflammation is likely to be one of the at least contributing pathways. This is some work we published online a few months ago, and it came out just this week. This is looking at a sub-study of the balanced delirium trial where patients were randomised to a deep anaesthesia versus a light anaesthesia. And what you can see is that post-operative delirium was significantly higher in the deep anaesthesia group, so that's the BIS-35 group, where we saw an incidence of 28% post-operatively versus 19% in the lighter anaesthesia group. Similarly, at 12 months, patients in the lighter anaesthesia group classified for cognitive impairment according to the abbreviated mental test score in 9% of cases, whereas in the deeper anaesthesia group, 20% of patients classified for a significant impairment in their cognition at 12 months. This study also showed that patients who experienced delirium had an increased risk of an unplanned admission to intensive care. As I've already said, things that the literature has told us we saw in this study: increased length of stay, increased risk of MI, higher incidence of cognitive impairment, increased one-year mortality, and a time with burst suppression that was significantly greater in the deeper anaesthesia group compared to the lighter anaesthesia group. So this brings me to brain ERAS. How can we look at the function of an ERAS protocol to reduce perioperative neurocognitive disorders? This is something I've been working on with the group at my hospital at Weill Cornell, talking about brain ERAS. And I won't go into it in detail because of the time restrictions, but just to highlight that this is something that we need to be intervening from the very first moment surgery is discussed with the primary care physician until well post-discharge. We need to know that these patients are having assessments and are having every opportunity to prevent this cognitive disorders from occurring. But this can't happen alone. And what I've done with the next couple of slides is try to give you an idea of how this protocol should become part of all surgical ERAS protocols. This on its own won't work. This needs to be embedded into ERAS protocols in general. For example, I have used our enhanced recovery pathway for spine surgery from our hospital, from our department. And this is actually interesting because it talks about what is done preoperatively and that it's ordered by the surgeons or surgical staff. On the left, you can see what our brain ERAS suggests are the things that need to be done 1 to 2 weeks prior to the patient presenting for surgery. They need to be assessed cognitively, functionally, frailty, delirium, education about delirium and how it can be prevented, or what to expect if they experience it. It's a terribly distressing experience for patients and their families. Perhaps they need a referral to the pre-evaluation consultation for a pre-anaesthesia consultation. Perhaps 2 weeks of improving lifestyle, increasing exercise, prehabilitation might help, and as I've already said, a pharmacy review. On the day of surgery, on pre-op and on the day of surgery, again, we need to check their cognitive status, and immediately preoperatively, we should be making sure that their pharmacy, that they're not on a large set of unnecessary medications. In terms of intra-op guidelines, as I said, there's very little at this point in time that can guide anaesthesia practice to reduce cognitive impairment. But we would suggest, based on the results of the study that I just presented, the BALANCE study, that targeting a light anaesthesia, being conscious of not risking awareness, is something that is possibly going to be beneficial to reducing post-operative delirium and the long-term consequences of that. And of course, optimal hemodynamic management. That's obviously something that's part of the anaesthesia protocol, not specifically for brain ERAS. Post-op guidelines: while the patient's in hospital, use the HELP strategies to reduce or prevent delirium. Make sure the patient has their hearing aid, their glasses. You can imagine this patient who's been wheeled from room to room, staring at the ceiling, and they can't hear and they can't see. It must be an incredibly disturbing and distressing experience, and no wonder the patients are feeling confused. Early mobilisation, optimal pain management, all of the same things that are part of an ERAS protocol should be part of this during the admission period for these patients. They should be screened for delirium at least once per shift, and perhaps referred to geriatrics if a problem is identified. Post-op pain control, really optimal pain management, apart from all the things I've just said, are what should be part of the brain ERAS protocol during hospitalisation. Discharge, patient and family should be educated, and again, don't discharge the patients with delirium. In our experience, there is a very significant number of patients discharged with hypoactive delirium. Discharge medications, perhaps you need to refer the patient, and perhaps you need to make sure that they're functioning appropriately on discharge from the hospital. So, in summary, assessing risk for perioperative neurocognitive disorders is important. Key risk factors are age and pre-existing cognitive impairment. Screening to identify at-risk individuals may include or encompass more than one small screening test. It may include cognitive function, frailty, and biomarker evidence. A multidisciplinary approach is essential. We can't do this without nurses, without allied health, without physical therapists, without geriatricians, neurologists, and psychiatrists. This has to be a multidisciplinary approach, and that goes from well pre-surgery to well post-discharge. And my last point, we need to implement brain ERAS protocol to surgical ERAS protocols. Thank you very much.
Thank you, Dr. Everett. And as you can see, we truly have a world expert. And Dr. Everett's going to be around for the rest of the conference, I think. And we will be having questions at the end of all three talks. So you've heard about the basic science, you've heard that this is a problem, and it is a big problem. And so I'm going to tell you about what's going on nationally at a US level that can impact this important problem. And I'm going to put it in the frame of enhanced recovery. And before I start my talk, let me just remind you that earlier this year in JAMA Surgery, an editorial stated, post-operative delirium is the single most compelling complication for our national surgical community to address. So that is what this talk is about, and then my colleague, Dr. Decker, will be talking about practical actions at the front line. So these are my disclosures and associations. What are the issues? Well, the population worldwide is aging. I'm sure all of you see in your daily practice that patients coming, particularly for inpatient major surgery, are getting older and frailer. Delirium and post-operative neurocognitive disorders are the single most commonest post-operative complication in patients over 65. And yet, how often are we talking about that at conferences like this? Hopefully this is a new trend. So what can you do about it? What's going on across the US? And why does it matter in ERAS pathways? Well, I think you've already heard. It's going to increase your length of stay. It's going to increase other complications. It's going to increase discharge to places other than home and mortality. So we want patients that come in, have a great experience, and go home. And so you have to think about this. So you all know these data. By 2035, there'll be more older adults than younger adults in the US. The patients are more complex, and they suffer disproportionate harm. So we need to think about this actively as part of our ERAS pathways. And actually, this slide comes from a talk that Dr. Lee Fleischer, who's now the CMO of CMS, and I were going to give last year to the American College of Health Executives, because they were really interested in this topic, because executives at American hospitals want to know about this because it costs a lot. Age-friendly health systems. You might have heard of this. This is an initiative by the John Hartford Foundation, the AHA, the Catholic Hospital Association, and IHI, tackling the fact that we need to think about older patients in hospital. We need to think about what matters to them, what are their goals of care, what medications are they on, their mobility, and their cognitive function. So all, again, central to a successful surgical pathway. And this is that initiative, which I can't remember, but there's tens of thousands of hospitals across the US involved in this. And then on the right of your slide, the American College of Surgeons Geriatric Surgery Verification Program. How many of you are involved in that? Anybody not? Oh, interesting. It's quite challenging. If you want to, you can download it, just Google geriatric surgery verification. It's really quite a serious thing to get into to make sure your surgical patients are safe, but you will have that verification. And they spend a lot of time in this program talking about cognitive disorders, delirium screening, frailty screening. So again, if you're interested in this, the contents of these talks are important. As an anesthesiologist, the ASA in 2016 launched a public health campaign. They felt that this issue was so significant that we really needed to make it not just about anesthesiology, not about surgery, but across all these major organizations, including the AARP, which I'll talk about in a moment. These are the numbers that we've put on some infographics. I'll show you again in a minute. But 30 to 40%, and I'm talking about delirium here. Dr. Everett was just talking about cognitive dysfunction longer term, but when you just talk about delirium, 30 to 40% is preventable. The costs are huge, and we could save huge amounts of money by addressing it. Not all of it is preventable, but there's now some evidence that there's a dose response to it. Even if it happens, if we pick it up early and mitigate it earlier, then we can prevent some of the longer term harm. The ASA Brain Health Initiative was founded by Dr. Dan Cole, who was the then president of the American Society of Anesthesiologists, whose father had never been the same again after surgery. And how many of you have heard that phrase? So this came out of a very personal, emotional experience. This is, again, that infographic, and I will say that I would urge you to go and have a look at the American Society of Anesthesiologists' Perioperative Brain Health Initiative. It's part of the ASA website. You can download the resources, and this is the sort of thing we put up there. We're doing it deliberately so that you don't have to go and construct the slides when you want to go home and talk to your colleagues about this. You can just download these images and infographics with the references and use them. So please feel free to do that. So it's just, again, iterating what I said previously. This is a really big issue. So I left most of the science to Liz, but this is one slide. This is from Sharon Inouye's group at Harvard talking about the incidence of complications. It's a busy slide, but basically patients who experience delirium and 3 to 4 times risk of length of stay greater than 5 days, 3 times increased risk of 30-day readmission, etc., etc. These patients, delirium occurred more frequently than all other major complications combined in this surgical population. So again, time to pay attention to this. I don't know how many of you have experienced it, but patients are starting to ask about this. They've read the articles. This is an article, the one actually on the left is from the New York Times. Then there's a headline from the Wall Street Journal. And then the AARP are right on this. We held our first summit at the AARP headquarters in Washington. So they are empowering their members to be asking, when they go for surgery, what are you going to do to protect my brain? So expect these questions and expect to have some answers. So just again, the ASA, the AARP, and that was in June 2018, we held this summit. They now publish global health and brain health publications on their website, and also, again, flyers for patients to download, to take to their surgeon, to take to their anesthesiologist and say, what are you going to do for me with regard to my brain? So the goals of the ASA initiative were to help us and focus our thoughts on identifying patients at high risk, encouraging us to talk about it with patients and families. Now, I know there can be concern that we don't want to scare patients, but at this summit, we heard loud and clear from AARP members and their families that they wanted to know about this. They wanted to know about their risks. Families who'd had a loved one experience delirium or a brain fogginess that went on and on want to know that it's a risk, and they want to know how they can help if it happens. So Dr. Decker will give you some practical thoughts, I think, on how you address this on a day-to-day basis in your clinical care. And then educate us, ourselves, everybody in the perioperative care team about the risks of this and what we can do to help patients and families get through it if it happens, how we can lessen the impact, and what can we do to help avoid it if possible. So again, this quote, "We only wish someone had educated us before the surgery. The emotional toll on the family was overwhelming, and much of it could have been avoided. Even if it happened, if we'd known what was going on, it would have been so much better." So again, back to the ASA Brain Health website. That's the web address. It is free again. You don't have to be a member of the ASA to get in there to download resources. There's a lot of resources on there. We try to keep it updated with the recent research, but also with more practical stories. So there's a podcast there with me and Sharon Inouye, but we make it very, very practical. It's supposed to be for frontline clinicians and patients. There's a section for patients. So this is one of my colleagues from Hoag Hospital in Orange County telling what they did. And also, for those of you with the MBAs in the room, in Orange County in California, a very informed, wealthy population, it was a selling point for the hospital. You know, they actually openly talked about it. We have protocols to care for your brain, less incidence of delirium. So again, we're featuring those kind of stories. There's lots of, again, references. There's major guidelines out there for those of you who want to know more. This is one of them from Miles Berger. The reference is there, Anesthesia and Analgesia 2018. It gives you guidelines, good practice. I don't know whether we're sharing these slides afterwards, but we can certainly give you a list of key references. There's lots more information out there now than there was a few years ago. So that's 2018. There's this nice infographic and paper from the American Society for Enhanced Recovery. I don't know if we're allowed to talk about them. And Perioperative Quality Initiative Joint Consensus, but I particularly like the infographic. It's clear, it's the basic things you need to do. So lots more information out there. However, are we doing it? So myself, Stacey Diener, Lee Fleischer, the geriatric committee of the ASA, we surveyed all ASA members late 2019 and asked them, given all these new evidence-based guidelines out there, and we practice evidence-based medicine, what are we all doing about it? Well, Of course, the survey did not have an enormously high response rate, but there are a lot of anesthesiologists in the US, so this reached a lot of people. Now, you can see the numbers. If you look there, if you're at an academic medical center, you might screen 20% of the time for delirium postoperatively. If you're in a private practice group, it's less than 10%. If you're doing comprehensive geriatric evaluation at an academic medical center in the US, less than 6%. If you're in private practice, 1.7%. So there's a big gap between the evidence-based guidelines and what we're actually doing. It may be improving. You know, these talks about delirium and cognitive dysfunction are becoming more popular, but we still have a long way to go. On that note, the ASA working group, we decided to take a very practical and pragmatic approach. There are all these guidelines out there, both in the anesthetic, the surgical, the geriatric literature, and they're worldwide. And yet, we found evidence that not many people are doing them. So we decided to get an international consensus expert panel, Dr. Everard was one of them, and survey them and show them all the international guidelines of delirium prevention and cognitive dysfunction prevention in hospital, and ask them what they thought the 6, it was actually 5, but they tied on 2, so it became 6, most important and feasible things that we could do. So ideally things that didn't cost a lot of money, they could be done in low and middle income countries, and you could start doing them tomorrow. Not terribly exciting. Anesthesiologists love brain monitoring and things, and this is not particularly exciting, but effective and it's probably low cost. And we took a choosing wisely approach. You know, what would work for patients, what's free from harm, and what's truly necessary. And this is what we came up with. Again, really not very exciting, but it will make a big difference. So perioperative education for all us as providers and patients and families. Cognitive screening preoperatively to identify at-risk patients. Screening for delirium postoperatively. And we, again, took a very, very sensible frontline provider view of this, and we said preoperatively only for emergency patients. Ideally, it should be for everybody, but we felt that's not going to happen. So who's the highest risk group? The emergency surgical patients. Non-pharmacologic interventions, which are the glasses, the hearing aids, the orientation, opioid-sparing multimodal pain management, and no routine antipsychotics or anxiolytics. There's no evidence for that at all. So those are the 6 things that this international consensus group came up with. So what can you do? And Dr. Decker's going to talk about the front line. I'm going to talk really at a hospital level. What can you sell your chief executive on? First up, the education thing. We should be thinking about what we're going to tell patients and families, how we're going to standardize that, and what protocols we're going to implement across the whole hospital. Again, if you're struggling to worry what you can say in your practice to patients and families, we have some help here. Again, on the ASA website, we worked with the American Geriatric Society to standardize wording for patients and families, and you can go into the website, you can download this flyer, and you can give it to your patients, or you can copy the wording, you know, you can use this. It's supposed to be a help to get you started so you don't have to start at the beginning. From a hospital priority, and again looking at the American College of Surgeons and American Geriatric Society's guidelines, an expert anesthesiologist in geriatric medicine in each department, perhaps a surgeon who has a specific interest in this as well, increased awareness of at-risk patients, standards across the organization, and standard frailty and cognitive screening prior to surgery. And get your executives involved and make the business case about why this is important. Dr. Everett mentioned Sharon Inouye's Hospital Elder Life program. Very simple, again, not rocket science. Use of volunteers, mobilization, things that are standard to ERAS protocols. Here's just one paper that shows from an enhanced recovery perspective what a difference this would make. This is a study by Chen. There are others using the same approach, and this is major abdominal surgery. And the blue line is the patients, the lower line is the patients that had this modified help protocol, so orientation, chatting with volunteers, early mobilization, and the dark line is the control group. Length of stay was reduced by 2 days in the intervention group. So again, there's your business case. As Dr. Coombs said, one Louis Vuitton handbag maybe. But people will take, if you need some funding to get geriatric pharmacists into clinics and things, here's your case for your funding. Justine and I wrote a very practical article, which I'll leave her to talk more about, but really some things like what do you say to the patient that you find is very cognitively impaired, who's just driven in and has already fully consented for surgery. So the practical things that impact us on a day-to-day basis. On the ASA website, I took my implementation science background, and you can link to that, again, free, downloadable. If you're actually going to do this, what are some quality improvement tips to help get going? Things like get the data, and Dr. Decker will talk about that. Partner with patients and families, get them actually involved in how this can change things. For those of you, if this not from the US, and I think most of you are, in the UK, we have a quality improvement compendium on the Royal College of Anaesthetists website. It's freely downloadable. You can download it here, and we have specific sections on delirium and on frailty. So again, just more tools, techniques, resources. And again, the ASA Monitor, which of course everybody reads these magazines that you get left around in the operating room, and every month it features something now about delirium and brain health. And this is just the one I did in September with Dan Cole about the turning knowledge into action. There is a link with frailty. There's patients who are frail are likely to have an increased incidence of delirium, so working on frailty with prehabilitation preoperatively may help make a difference. Can you train the brain? Well, there's some interesting early studies. This is one from Michel Humidin in JAMA Surgery I think it was earlier this year, but and patients, they excluded patients with cognitive dysfunction preoperatively, but they did give older patients some exercises on iPads, and there was improvement. So that's early work, but definitely more to go there. And this is the case I referred to. This is work again from the group at Harvard, Sharon Inouye, and it's the 1-year Medicare costs associated with delirium patients undergoing major surgery. And this is the accompanying editorial, which says, the single most compelling complication for our national surgical community. So if we think about it, there is a big gap, I showed you, between the evidence-based guidelines and what we're actually doing. If we all did one thing, we'd move towards closing that gap. So I know we've got a multidisciplinary audience here, so I'd task you to go home and think about that. So you've heard that it's common, some of it's preventable. Even if it's not, we should be telling patients and families. We've got guidelines, we've got key actions. I'm making a call to action for all of you after this meeting to go and think about this and what you're going to do, because you can make a difference. So thank you very much. And on that note, I'm going to introduce the final speaker in this session, and we'll take some questions at the end. But Dr. Justine Decker is an assistant professor at Keck Medicine of the University of Southern California in Los Angeles. And she, during her perioperative fellowship, started working with me on this. And she really took the concepts of this ran with it and turned it into a really impressive multidisciplinary project at CAC Medicine of USC. So thank you, Dr. Decker.
Thank you for the introduction, Dr. Peden. So I'll be speaking about getting your own perioperative brain health initiative started. I have no outside funding or financial disclosures. I did have a small institutional team building grant, 2019 to 2020. So today I'll talk about what are the key steps in getting a brain health initiative started, go through our implementation experience and some of the troubleshooting we had to do, talk about what our patients' experience is like, and then also some of the preliminary outcomes we've seen. So the key implementation steps are get started. That's number 1. 2, identify who your champion's going to be. 3, find your partners. You can't do this alone. 4, establish what your pathway will be within your institution. 5, promote education and awareness about this topic. And then 6, system integration. So first is just get started. We began by screening all of our older patients for cognitive impairment and frailty through our preoperative screening clinic. This establishes the prevalence of this problem at your institution. There are many screening tools you can use. We utilize the mini-cog, which is a 3-word recall and clock drawing activity, and a frail scale. We chose them because they're quick, easy to administer, can be done in parallel with other clinic duties like vitaling our patients. And in the beginning, we did face some challenges with staff recognizing this as something that was a routine part of an older adult's pre-op evaluation. But now it is seen that way. It's seen as routine. We also fail to identify these patients subjectively. We did a blinded study within our clinic, and we asked our nurse practitioners and anesthesiologists who spent 15 to 30 minutes with these patients, eliciting a medical history, going over pre-op instructions, doing physical exams, and asked them, how do you think your patient did on their mini-cog afterward? 40% of the time they were able to correctly identify how they did. So it's even more unlikely that we're going to be able to do this subjectively in a busy clinic or at the bedside right before wheeling into surgery. So these are a few examples of some of the clocks that our patients have drawn. These are all patients without a cognitive documented history. These are patients who came in, gave us their medical history, took down instructions, asked questions, and this is how they depicted a clock that's supposed to show 10 past 11. The results of our cognitive screening provided concrete data to solidify the brain health concept and sound the alarm about this problem within our patient population. So this highlighted the need for action and a multidisciplinary team-based solution, which brings us to number 2, which is identify who your champion will be. They will be the ones to sound that alarm, to lead the initiative, and be responsible for implementing these national guidelines for the older surgical patient within your institution. Next, an interprofessional approach is necessary. It must incorporate frontline clinicians and caregivers across the perioperative spectrum, and it must draw on their expertise in the care of the older surgical patient. So think about your institution. Who's likely to become your partner? We recommend reaching out to these likely partners to identify key champions from diverse backgrounds. So I began just cold calling and emailing our geriatricians. I found a partner in Dr. Kalustian at our institution who knew a geriatric pharmacist who would be interested and an occupational therapist that may want to be involved. And it kind of snowballed from there. Everyone knew someone else who was interested in being a part of something like this. Ultimately, our perioperative team consists of geriatricians, pharmacists, anesthesiologists, surgeons, hospitalists, nurses, occupational therapists, volunteers, and our data analytics team. Every institution will have its own different strengths and resources, and they may lead to a slightly different composition of your team, and that's okay. We held brief weekly meetings to come up with multidisciplinary consensus for our age-friendly pathway. established short and long-term goals, and it also gave us an opportunity to meet regularly to come up with team-based solutions to any hurdles or issues that arose along the way. This is an old photo of the beginnings of our team, but we've since expanded to include everybody listed here. They're all from diverse backgrounds and all different levels of training and experience. And our success is a direct result of all their hard work. I couldn't ask for better partners. Once your team is assembled, now you need to build your pathway, and the key here is to really do what you can with what you have. Determine what resources you already have available and strategize how you can utilize them in your age-friendly pathway. So what key actions you choose will depend on your specific patient population and, like I said, what resources you already have available to you. We pooled our unique expertise, our societal recommendations and resources, and put it into a robust care plan covering all areas of the perioperative spectrum. We chose key things that were best practice, easy to implement, and low cost. So we used a staged rollout with respect to both our perioperative phase and surgical specialty. So we started in the preoperative phase with one surgical service and then expanded from there. This allowed for us to really gauge our capacity to handle the volume of patients we were looking at. We could promptly address hurdles through group consensus and refine the workflow in a really small number of patients before it became a large volume of patients. At the same time, while we were doing this, we were working with IT on the back end to start building out some of the infrastructure and incorporating ourselves into the EHR, creating discrete entry of metrics so that it could help us with tracking going forward. So in any quality improvement project, there's always going to be hurdles that come up. Some of them we can anticipate, and some are not so are unanticipated. So, one of the things that we looked at was, integrating ourselves into the EHR that's anticipated. We had early involvement with IT and data analytics to create that infrastructure to support our sustainability and then allow for reporting of outcomes and pathway compliance. While this was being created, we started looking at our baseline data for accuracy. So one of the things we did was we pulled, what's our baseline incidence of delirium in our hospital postoperatively? And we found it was less than a fraction of 1% and not really agreeing with what we see clinically. So it's not being documented accurately. And that's a common problem. So we did an extensive chart review. We looked through patients' perioperative courses who had been screened but not yet gone through the care pathway and looked at, markers of delirium as a diagnosis and also surrogate markers. So patients who were documented to be confused, patients who were inappropriately removing lines, tubes, drains. They had one-to-one sitters or restraint orders ordered. Patients who had had a head CT, which was not indicated based on why they presented for surgery. Patients who had had positive delirium screening and still were not documented as having delirium. Or psych consult or antipsychotics that were administered when they were not previously on these medications. After that, we were armed with the information that now we can figure out why these aren't being documented appropriately and can be corrected going forward. And then we can work on improving not only the documentation, but then, can we see reduction in these events in the future after our pathway's initiated? So other hurdles were unanticipated, like Dr. Peden mentioned, with issues with driving and consent. So we had a patient that was identified with cognitive impairment on their mini-cog screen. We had an occupational therapist who came and did confirmatory neurocognitive testing with the patient and then brought up the concern for safety of driving. This patient drove themselves to the clinic that day and didn't have another person with them to go home. With the patient's permission, we spoke with his daughter. She actually had concern for his driving already. She had brought it up several times and was really looking to have this discussion with his PCP, which he was hesitant to do. After we brought up this concern, he was less hesitant to. Now hearing this from a healthcare provider that there was concerns for his safety. We actually sent him in an Uber that day and had his daughter pick up his car later that evening. But going forward now, we ask all of our older adults coming into clinic to bring a family member or friend with them. So there's a short-term solution for that patient and then a longer-term solution going forward. So once these initial implementation hurdles were addressed, we used feedback loops to really refine the pathway. And all that answered was basically one of these two questions. How do we make access and convenience for our patients and family better? And then how can we more efficiently communicate amongst ourselves from the outpatient to the inpatient, and then bridging those transitions of care, whether that be in physical space or the team members at the bedside. So promoting education and awareness, this is two-pronged. This is within the healthcare system and then also with patients and their families. So raising awareness about this topic within our institution began with educational in-service, department meetings, grand rounds, providing information about this common complication, the prevalence of this problem within our patient population, and what is our institution's plan to help or to combat this. Our team has representative champions or key stakeholders from all the different departments that provide care throughout the perioperative spectrum. And those key stakeholders are the ones that continue to disseminate that brain health message within their departments, elicit feedback, share updates, and really expand that reach of awareness and teamwork throughout the system. It fosters like a collaborative desire for change instead of an outside authoritative mandate to change. With respect to patients and their families, we listen to their concerns about cognition and memory around the time of surgery. We ask them about previous experiences and potentially provide that validation and give a name to a problem that they may have experienced before. We discuss the risk, including that this is common and it most often will resolve on its own, but if it does happen, to let us know. There's things that we can do to help. There's things that your family and friends can do to help around the time of surgery. We encourage family and friends to be present, to be included in this discussion, and then to really assess and watch for changes, alert the care team, and then empower them to help with reorientation should this occur. For system integration, make sure you're making data-driven decisions. Make sure you're leveraging the technology that's available to work for you. So to facilitate communication and alerts that can be used in real time, building out protocol compliance dashboards and reporting to give updates back to the frontline care teams and your administrators. Elicit feedback and make sure that we're constantly doing that with the frontline care team to adjust and refine as you're going forward. The ultimate goal here is a multidisciplinary approach to surgical optimization and planning, and to really transform your culture, set the standard of what you want your institution's perioperative care of the older adult to be. So this is just to show you a timeline of how long this all took to do. So throughout our pilot, through opening up to additional service lines, took about 18 months in total. And what do our patients experience? So prior to surgery, patients are seen who are having elective surgery through our preoperative screening clinic. All patients 65 and older are screened for cognitive impairments and frailty. We have the opportunity within our institution with our occupational therapy team. They have residents that work with them, and they're actually on call to come to our clinic. So when somebody screens positive, we can call them up, they will come to their clinic appointment and do brief neurocognitive testing to confirm impairment. If patients are positive, they're given information and resources that are available to them around the time of surgery. So this is the handout that we go over. It's about surgery and brain health, what the patient and their family can do to reduce their risk around the time of surgery, what we're going to do for them around the time of surgery. And then on the back, we have an easy-to-read list of medications and pictures of the actual over-the-counter medications at home that may be potentially harmful. We go over which to avoid or try to reduce around the time of surgery. And like Dr. Peden said, this is one that we had created, but there are others that are infographic-based that are readily available on the ASA's website. You can download and use those as well. Patients who are identified at increased risk are offered a referral to our GAP program, which is our geriatric assessment program. We have a geriatrician and a geriatric pharmacist that will do either an in-person or a telehealth visit with patient and an appointed family member. They'll go over, goals of care, identification and treatment of reversible causes of impairment, identify any high-risk medications they're taking preoperatively, and polypharmacy, and try to reduce those safely if possible. They go over perioperative risk mitigation strategies for the inpatient care team and make those recommendations. And then they also go over with the patient and their family what are the goals of care, who is going to be your point person or your partner in this, and be co-responsible for the instructions and the management around the time of surgery. And then they also make a bridge to the primary care provider. They'll call them up and contact them and say, your patient was seen here, they screened in for cognitive impairment, these are the things we're going to do around the time of surgery for them. After surgery is done, we're going to call you and let you know how their hospital course went, bridge them back to you, and should you want more help or assistance afterwards with a long-term care plan and interdisciplinary evaluation, we're available to help with that if that's something that's outside of your wheelhouse. So we notify the surgical and anesthesia care teams about the patient's cognitive status to help guide their surgical and anesthetic management, and also prompt the discussion to talk about this risk. Post-operatively, we identify patients with the decals seen here to alert all members of the care team that this is a patient that needs a little extra resource around the time of surgery. We've engaged nursing champions whose action items include to return cognitive aids, so hearing aids, glasses, dentures, placing patients in rooms that are near the nurse's station or have windows, or a reduced nursing ratio if possible, or not to give a nurse multiple patients who have been flagged for brain health, okay, to really spread the resources appropriately, and staff. Protect their sleep-wake cycles, so scheduled, engaged volunteer visits during the day or out of bedtime, and then at night trying to keep quiet hours and avoid unnecessary interruptions if possible. Delirium screenings done at least once per shift, or if there's any change in mental state. Co-managing hospitalists and pharmacists are on board to help prevent inappropriate or potentially harmful medication administration during their stay. We have alerts on key high-risk medications. So for an example, if you're trying to order prescription sleep aid in those over 65, an alert would come up saying that this may be potentially harmful in this patient. Consider a sleep hygiene order, chamomile tea, melatonin first. If the patients do have delirium events, we proponents of reorientation and non-pharmacologic interventions. And then prior education with family and friends can actually help. They can empower them to help reorient and make it a little less scary for them should it occur. At discharge, there's a pharmacy review of their medications, and an alert is given for potentially high-risk medications being sent home with reduced dosing or alternatives, all based on BEER criteria are suggested. There's bridging of care, like I said, back to the patient's PCP, and we offer the GAP program in full should they want to come back for that at a later time. So the goal here is to just provide the resources for improved outcomes of our older surgical patients, assess the prevention strategies that we put in place on post-op delirium and delayed neurocognitive recovery, and really raise awareness about this common complication. And just like has been said by Dr. Ever and Dr. Peden, brain health initiative and ERAS are not mutually exclusive things. These should be one and the same or be a component embedded within. How do we enhance the recovery and surgical experience in an age-friendly way? So we want to make sure that we are screening patients for preoperative cognitive impairment and frailty to identify those that are at the highest risk. We want to draw from within your system, what are your strengths, what are the resources you already have, and how do you incorporate key action items for brain health into them? And then look at your ERAS pathway. Go through and review the perioperative course for your patient. And maybe through the lens of some of the things you've heard here today, how can those be slightly adjusted for the older adult? I'll give an example with our ERAS pathway at our institution. When they first started, a lot of ERAS had preset order sets. So every patient, when they came in, was receiving, for example, 300 milligrams of gabapentin 3 times a day. They were given this at home for 3 days prior to surgery and then throughout their hospital course. So we had advocated for patients over 65, especially the ones that rolled in for cognitive impairment and are in this pathway, please start with 100 milligrams at night, titrate up from there. Just to assess that they're safe with this medication and make sure we're not doing harm in this population. Some of the preliminary outcomes we've seen are improved compliance with their preoperative instructions when they were assigned a partner to be co-responsible for these items. We've seen changes in anesthetic management. We've seen less benzodiazepines given as a whole or reduced dosages given. We've seen more multimodal analgesia. We've seen providers are more apt to use BIS monitoring and age-adjusted MAC to make sure they're not overdoing the anesthetic. We've seen increase in delirium prevention plans specifically laid out in our hospitalist notes for inpatients. We've seen decreased ordered and administered high-risk meds postoperatively and at discharge. We've also seen in a few cases the family and patient and care team together opted for either a less invasive procedure or to put off surgery at this time in a few select patients. If you have any questions or comments after, you can always contact me.
So I know we're a little bit over time, but we're just going to take about 8 minutes, so going to 3:30. If I can ask Dr. Everett to come up and please, Justine, have a seat. And who has any pressing questions? And we will be here afterwards as well, if you'd like to.
So I guess my biggest question is, we've been consulting geriatric medicine for some of our
Do you want to, maybe, so just because I can hear, but probably people behind you can't hear.
So we've been consulting geriatric medicine for our octogenarian patients after major abdominal surgery, but my question would be for patients that come in already on like antipsychotics or anti-anxiety meds. My concern about not continuing those postoperatively has been that they're going to withdraw, or if they're used to taking these medications, even if they're PRNs, like Xanax for one thing. That, I swear, everyone in North Carolina is on Xanax. So my concern is, if we hold that, are we going to cause them to have cognitive impairment postoperatively? And what's your recommendations with patients already taking it?
I think, Justine, you're probably the best person to answer that.
So I'm coming from Los Angeles, so we see a lot of benzodiazepine use in our older adults too. Our geriatric pharmacist works with us in patients who are chronically taking these medications, daily. You can taper down, but it's not safe to abruptly stop them. So we make recommendations to try to wean down or reduce those medications around the time of surgery, and then while they're inpatient, start with the lower dose that they're used to, be cognizant of how much we're giving them, especially in the lens of concomitant use of opiates and other sedating medications that we may be contributing to polypharmacy, and really monitor them more closely.
Thank you. I mean, that's a great question. It goes back to the ERAS thing, doesn't it? The longer we can think about getting these patients in contemplation of surgery, and we can start doing some of the things that we know help, such as tapering these medications. Next question, thank you.
So with older patients, I often struggle with the benefits of same-day discharge versus keeping them overnight for observation. So what would the data say as far as, particularly now that we can't have family members overnight in the hospital anymore for the last couple of years? I have patients in their 80s or 90s, sometimes they're pushing 100 more recently. And the question becomes, well, should we keep them overnight, or are we risking them having more delirium by staying in the hospital overnight? Or are patients who are older more likely to be at risk for falling at home if we send them with the same day discharge? What would the data say around that?
Liz, you probably.
It's a great question. I think there are a few things to consider. In particular, is the patient going home alone or not? I think that's probably one of the most important factors. If the patient's going home accompanied and someone will stay with them for at least the first 24 hours, then perhaps home is a better place. But also, I think the issue of have they attained their preoperative cognitive and sort of thinking ability before they go home. We recently looked at a group of same-day patients, so just having colonoscopies and going home, and a significant proportion of those relatively healthy patients went home same day and with a 2-point decline on their Montreal cognitive assessment. So it's obviously an individual assessment to make, but certainly I think that sending an elderly patient home alone is definitely asking for trouble.
I mean, that's a great question. One of the things we heard at this AARP summit, and the people, the members of the public who were there, were patients or family members who'd experienced delirium or delayed cognitive recovery. And there were some pretty impressive tales from patients who were not that old, you know, in their mid-60s, who described for several days after surgery not being able to tell the difference between a green and red traffic light, but they were driving. So, you know, I think we really need to be thinking hard about some, you know, particularly in at-risk patients, about the cognitive evaluation and screening for delirium as well before they go home.
Absolutely.
Thank you very much. Another question at the back.
Hi there. Thank you to all three of you for phenomenal talks. I'm a vascular surgeon, and many of my patients are older and have cerebrovascular disease and are at really high risk. But I think that probably many of my younger patients are also at high risk. Are there specific criteria that I can bring back, or maybe I just need to look at your web resources that you provided about, other than age, as a general screening through my clinic, people who I could identify to potentially get help?
Liz, again, you probably know the data.
So you're meaning in terms of risk factors for younger patients?
Yes, thank you.
So the work that's been done looking at neurocognitive disorder post-operatively suggests that middle age, younger and not, so for adults prior to sort of around the age of 60 tend to be fairly resilient and are much less likely to experience any sort of delirium or cognitive impairment. That said, there are a number of people who do experience it, even in that younger age group. So I suppose the factors that you really would need to lean on are undertaking a cognitive assessment preoperatively, and also a subjective question. One of the things that we missed in anaesthesia and surgical research in this field for, as I said, you know, more than 100 years, was actually asking the patient or their family if they had felt they had had a decline. One of the issues with high-functioning individuals is that they can drop considerably and still be performing at a very high level. So in some people, and particularly that middle age group, if they think they've experienced a decline, that may be something that's, you know, requires further investigation. I don't know that I've really helped you.
No, you certainly can. I mean, the majority of my patients are 55 and on dialysis and have had a stroke in the past. So I mean, like, the age I think is less relevant, but some of these other risk factors I think are important. And honestly, asking patients who you think might be borderline is probably very sound advice.
Especially where they've got a significant comorbid burden. Absolutely.
Sure.
Thank you. Do we
Thank
have,
you.
Matthias, did you have one
Yeah,
last?
I'm intrigued by the comment about your assessment making changes in the surgical plan.
Me?
The last speaker.
Oh, sorry.
And where do you see is this going with awareness and the attempts we do to improve how these patients fare? Do you think it will expand eventually, actually, procedures we offer to elderly patients?
That's a good question. This was a very small number of patients that actually changed the procedure they had done. So we have screened over 5,000 patients, and I think there was 5 or 6 that actually wound up having either a different procedure, well, 5 with a different procedure, 1 that elected not to have surgery. So it was a very small number. In most cases, the surgeon was actually very glad we brought this up. They didn't really realize how much was going on behind the scenes and the dynamics of the family. What really mattered the most to the patient actually wasn't the end result of that surgery. It was spending more time with their family in the current mental state that they were in. So this was somebody who had mild dementia and was really afraid to lose that time with his family at the risk of having a more invasive surgery, and opted to continue with a less invasive procedure. So those are the nuance there. It's not a large number of patients.
I think, sorry, just to continue on from that, one of the things that is really important is patient expectations. And sometimes surgery might not be the very best option. And certainly in our work, certainly all of my team in Melbourne, we include a participant from a recent study on our protocol development, writing team, because what's important to the patients might not be what we think is important.
I think on that note we better end, but I hope you'll agree that there was a lot of interesting topics raised. We're all around for the next couple of days, and I'd like you to join me in thanking my colleagues for really
Next order of events, I believe, is a break for about 15 minutes, and then we'll see you hopefully all back for our first abstract sessions. And maybe one more round of applause for an incredible start-off of this meeting and very thought-provoking and inspiring talks. Thank you so much.